the report that came out, which I say, that lovely report, suggests more could be done to measure and understand the experiences of patients who are on waiting lists. How important do you think it is to move beyond this single measure of performance against a target and get a better perspective from of what the patient experience is? Who's on that?
Vitally important, so I think it is important. Waiting times and those target measurements are one measurement. It's not to say they're not important measurements and that they can't have real value in when you're looking at how organisations are performing, how efficient and effective they are, but what they don't look at sufficiently, we believe, and this is something that we've said publicly and we've said in the Assembly, they don't properly look at patient outcomes and patient experiences. And in fact, the Welsh NHS Confederation did our annual survey, patient attitude survey and public attitude survey around our annual conference in January. And that showed very clearly to us that what matters most to the majority of patients is the quality of care they receive rather than how long they may have to wait for it. And I think because we have blanket targets about waiting times, actually most of the time they're not necessarily directed at clinical need and what patients really need. So you will find that if you explain to people, you know, we are real people, we're also patients and users of the service, if it's explained to us that for certain procedures we may have to wait longer or may have to wait a certain time. And I think sometimes it's that we're very vague about telling patients what their expectations are. So the GP may say, oh yeah, I think you might, you know, I might make you an urgent referral. And then you think, well, what does urgent mean? Does it mean tomorrow, next week, 6 months' time? And sometimes it's that not knowing, I think, amongst patients, and that we don't manage their expectations properly. And sometimes you're quite happy to wait longer. You might not be in pain, it might not be having a particular impact on your quality of life, and you will well recognise that if that's the case for you, it might mean that you or a family member, when you have got something where your clinical need is that you're seeing more quickly within the waiting time targets is more important. And I think we, by virtue of having to hit certain targets, the nuances of those targets, we completely lose that, and we do lose the importance and benefit of patient experience and managing expectation.
I was to say today, anything to add around this area around, I'd say the notion of targets, but then where does that fit with what patients experience?
I absolutely endorse what Helen said. I think you've paraphrased the findings of the report really well there, Helen, actually. It's the single target doesn't measure patient experience. Even though patients will be classified into urgent and routines, and that's a good thing. The measurement which is done in the NHS doesn't allow independent members, board officers to actually distinguish whether those more urgent patients are indeed being treated more quickly. The survey we did actually echoed a lot of what Helen mentioned from the Confederation work, where clearly if a patient is in pain and what they're waiting for is life-limiting, they'll want their treatment quickly. But equally, many patients say they're happy to wait, and particularly where they are given information around how long a wait would be, why it was going to be that long. So I think that whole engagement with patients is important, but also asking them what it's like for them being on the waiting list. I think the survey we did as part of the study third up some really interesting information around, you know, what patients, what you think they would say is not always what they do actually think, and that engagement with them is really important.
Lots of issues listed in the report that could be tackled. If you thought there were priorities around waiting time, what would be the ones you'd say that should be tackled? As you started to mention some of those then, what would those main priority areas?
Well, I think it's very difficult not to put a label on a priority area, and I think probably we should change the way we look at our information and our priorities and put patient outcome and experience as a priority area.
And everything sits?
Well, it's an area that at the moment I don't think is given. I think we try, and as you said, there's a lot of information about patient experience, but how we actually then use that to inform how we deliver services, how we manage waiting times, how we look at our outpatient clinics. And I go back, and I'm a very simple soul really, I go back to having proper information and conversations with the public and with patients about managing those expectations, because I think our whole language with patients about, consultations and, consultation, what's that with, who's that with? It's with a consultant. Actually, it might not need to be, and we're doing all sorts of things. We're creating a position where patients, we're telling patients that they should be expecting one thing, and actually that's not what they're experiencing, and I think we'd have to marry that.
Language.
It's partly language, it's partly information, and then it's partly how that information is presented and how it's used to change services.
I'd agree. I think, but there are, for me, probably a number of practical priorities which, if you look at what we found in the reports, and you'd ask us the question, well, if you had to boil down, what does the NHS need to do to actually improve the position? I'd sort of, when you talked about the patient experience, we absolutely endorse that. Realistic planning, I think, would be something which is absolutely huge in terms of the current agenda. Plans which are based on a good understanding of demand and capacity. And that was a core finding of the report, and it's easy to say, difficult to do, but nonetheless that is a real weakness in the system at the moment. We've got a new planning framework that may help. I think the second priority, Chris, I would add to that would be looking at how we are maximising the current use of resources to be as efficient and as productive as possible. I think there's, even though the finances do mean that situations are squeezed, there's still a lot more capacity in the system that could be used. And the third one, Chris, would be the opportunities for the new planned care programme, for improving healthcare. They're great opportunities, but they have to be secured to secure a sustainable change. You don't want the single hit and move away. You want to do something which is actually going to make a difference in the long term.
I don't know, I was just going to say, there's a question I was going to ask next, which was broadly about how much of this, what needs to be done, is about improving what we've got already, and how much is about shaking things up and doing things entirely differently. Is it one, improve what we've got, or two, shake it all up and start again, or is it a mix? What is it?
I'm going to give a politician's answer and say it's a mix of the two, but, and I think it is a mix of the two. I think the point that you made is, we are where we are, and it's a system that's already set there, and there are some very set patterns, and we do have to get in and use the best bits of that system, because there are some really good bits. And one of the good bits is that we have a great primary care system, and that GPs as the gatekeeper, we need to support GPs and primary care, not just GPs, but other people working in primary care, to use that better. And I think one of my big frustrations, and I know it's one that's shared by all of you because this is what you tell us all the time, is that we have got some great examples of where shaking it up has made a real difference. So, and you put them in the report, Dave, the teledermatology in Cardiff and Vale University Health Board. I was astonished actually that between 15 and 20% of GP appointments are apparently from patients with skin conditions, but that's, I can accept that. But again the default position is the GP saying, don't like the look of that, or I'm not quite sure what that is, sending you off to a dermatologist. In fact, they're now talking to dermatologists, sending pictures of what's happening, and having conversations to decide whether you actually do need a referral or not. How it sounds so simple. It's happening in one place, and it's about to be rolled out throughout Cardiff and Vale, apparently. Why isn't everybody doing it? I think that it's something that we hear all the time, that we've got particular issues in our health board, or Wales is different because of the geography and the rurality and all those issues. But actually there's some very simple things that you would expect. When business has a good, if you take, I suppose, just supermarkets and internet shopping and how they've embraced that, it's a sort of similar shift, isn't it? That you do things differently, you embrace it. It doesn't replace the fact that you've still got shops that people can go around there with their trolley, but it's something that supports that. So the whole experience for that customer, that client, that patient, that member of the public is improved. So I think it is a mixture of the two, but I think a shake-up in some areas would not go amiss. And I think that you're in a perfect position to be able to sort of give that gentle kick and do some of that shaking.
You going differently, Dave?
No, not really. What I was saying was that the reports clearly showed there's scope to secure better use of current resources, but you can't just look at that efficiency save and productivity in isolation to achieve it. You've probably got to make some changes to the whole system. You know, so if you look at something like a length of stay in hospital, you won't necessarily get better lengths of stay unless you looked at the whole system in terms of primary care, community care support, picking up Helen's point about making better use of what's in primary care. So it's both. You can't do one without the other. But I think the key is to know where to target the attention, where to target your questions, the information you get at boards and committees, to know how you are currently using the resources in such a way to say, well, what are we doing in that area? You know, how are we going to challenge clinicians on their intervention rates, where they're vastly different across the branch and across the province of Wales. And it's, you know, I think it's having that intelligent information to ask the intelligent question, which is the first step. I do want to come back on the GP point, which Helen and Chris raised earlier. I think that's the referral bit of the pathway is perhaps the one which has received least attention in terms of how you support GPs to make good referrals. You know, if you get that right, you know, you're immediately on to the right footing on that pathway. We're publishing a report next month on orthopaedics, which carries on in a similar theme really, but looks just at that specialty. And we've looked at the CMAT assessment teams that are in place across Wales, which are in effect a triage between the GP and the specialist services. And where they work well, it's excellent. You know, you get a good quality dialogue between the GP and that team, and the patients get referred to the right port in the system, where it doesn't always work that way. And what you often will get was some GPs will just maybe send the patients across to that team without any real referral information, and the whole process gets elongated and prolonged. So there are some examples. It's working well in some places. It needs to be learned from more effectively. Absolutely endorse Helen's point about good practice. It doesn't seem to travel in Wales.
I don't think it travels anywhere, actually. It's consolation.
Probably not.
It's
but,
not just Wales.
Well, we could always change that today, couldn't we?
Indeed, that's part of today's. I mean, from opportunities to share some of this information around. That point of saying that better with what we've got, but some of this disruption, a bit of innovation, things differently where there's an opportunity.
Helen's going to follow up in the end.
Yeah, I just wanted to say that though. I think that, and I was the one who said a bit of both, make what we've got better. But I think again, in your position, it's about having that vision of what things can look like ultimately. And I think if we're not careful, we can sometimes get bogged down in the incremental changes that make bits of the system better. But actually, you know, prudent healthcare does offer us, I believe, and the Confederation has certainly supported this, does offer us a vision for a different way of delivering services. And it is about us taking more responsibility where we can in our own communities and using the plethora of, we're not just talking about the health service here, we are talking about health, social care, housing, education, community support, and I think that we, particularly with an issue like waiting times, if we're not careful, we're very focused on making waiting times better. That's important, and for all the reasons that we've already discussed. But actually, it's not an end in itself, and it's not the final goal. We need to look at it as a means to an end for a better support service, health and social care service.
Is prudent healthcare the answer here?
I think it's a great start to getting us to an answer actually, because it's about culture primarily, I think. And again, I don't want to trot out platitudes because we chuck in phrases all the time, and culture is one of them, and culture change. But we can see that cultures, things can change. I mean, this might be a bit of a banal example, and I apologise in advance, but as I say, I think things through simply. Who would have thought 20 years ago that we would be packaging and bagging up our own waste in different types of recycling? We've got our recycling, we've got our composting, we've got this, that and the other. I remember when there was a furore, and it is a long time ago, I admit, but when our bin men, and they are mainly men, weren't coming to the back of the house to actually collect our bins for us. How's that happened? We've completely changed our attitude to that, and I honestly think that prudent healthcare is a similar type of attitude change from us.
You have to be realistic about how long change takes, but at the same time, there isn't. You don't have huge amount of time to play with in terms of how sustainable the system is. You don't want to get to a situation where the system is so badly broken that you have to do something so fundamental with it. And I think so. There isn't 20 years to play with, I would say personally. I think I would land on the point which I think some of the audience have made already. It's a fantastic set of principles. It's provoking a really good debate. I think people aren't really arguing with prudent healthcare, so it's clearly hit a chord. It's how you connect that concept to reality on the ground. And there's lots of work under the banner making prudent healthcare happen. But it's something as practical as what does a good GP referral system look like? You need some practical guidance for health boards. So there's a link that probably needs to be strengthened between the centre, where the concepts are, and the ministerial concepts, and actually action on the grounds. And so press just some pausing and reflecting to see what needs to happen to turn the fantastic principles into some practical action.
Can I just wrap things up with one question, if that's okay? And it's to Dave and Helen. I'll start with Dave. Is that okay?
Of course.
It's a big question, I think. And it's about, and what difference, Dave, do you think independent members can make to the world of waiting times? Because it is a big question.
The answer is huge, honestly. Just picking that a little bit then. Clearly, the role that you perform in committees and boards around the scrutiny of plans and performance reports gives you, that's the way to land some of the questions. It's about challenging management, particularly around patient experiences. So what we talked about already is all the sort of, what I've heard, they're all the sort of right questions that you need to be asking. So it gives me great confidence listening to the debate that, I think people are tuned into the right areas. It's not just about scrutinising management, it's about actually understanding the barriers that management face. I think that's really important. So the engagement with the people who are trying to do this at on the day-to-day level is really important. And I think where independent members can bring some really useful input is their own personal experience, as well as sort of a mixture of challenge, scrutiny, and empathy. So it's but really it's it's asking the right questions, which is what today's all about. And hopefully today will be a help in that direction. The checklist around waiting times we've done is a much deeper checklist than we normally would do around some of our work, because we think that it's a complex area, but we didn't feel that necessarily independent members had been given anything like that before as a sort of very regular reference guide. And it's about unpicking some of those areas that we put in the checklist around the issues we discussed today.
That's partly your feedback on that later, what you think of it once you've used it will be useful. Thank you, Dave.
Yeah, very briefly, I think you've answered the question yourselves really, but as Dave says, by the discussion, by the points you're raising. I go back to what I said at the beginning, engage with patients and staff. I know you're doing that more and more, and in different, more targeted ways, if you like, and listen to that perspective. It's about you taking your place in helping to create that more transparent and open culture that we know now everybody is signed up to. We're all signed up to that. Our members are all signed up to it. But you can be really important through the sorts of, through your questioning, through your support. As Dave says, I think the other thing is that managers and officers are working very hard too. They want to get this right and they need your support. And part of that support is you being that critical friend and constructive criticism and pointing out things where things can be done differently and asking the questions that then promote change. Continue to be advocates. We need transformational change. This isn't about now making things a little bit better over here, and I think gatherings like this, where you can share experiences among your health boards and trusts, is really vital. And I think you can be the catalyst for taking some of these good practice examples that we were talking about earlier and really pushing and running with them. I've seen that, I heard from a colleague when I was at a WAO event in Cardiff that this is happening in Betsy Cadwallader. Why isn't it happening in our area? Why aren't we doing it? And find out why. There might be a good reason, there probably isn't. And again, that's very supportive of the organisations that you're part of.